Most people believe that if a surgeon recommends an operation, it must be the right choice. The doctor knows best. The hospital has the equipment. The paperwork is ready. Just sign here. I used to believe that too, until I started counting the patients who went in for routine procedures and came out permanently changed. Not better. Changed. A man who walked in with back pain and left unable to walk at all. A woman who survived open-heart surgery but lost 6 months of her life to complications nobody warned her about. Here's what nobody tells you. The older your body is, the harder it fights just to survive an operation. Not the disease, the operation itself. My name is Dr. Adewale Morgan. I'm a cardiothoracic surgeon with over 2 decades in the operating room. And today, I'm going to tell you the truth. The unfiltered, uncomfortable truth about 5 surgeries that carry serious hidden risks for people over 60. Let me ask you something. If you take a brand new car and a car with 200,000 miles on it and put them both through the same stress test, do you expect the same result? Of course not. And yet, for decades, medicine treated a 70-year-old body the same way it treated a 40-year-old one. Same surgical protocols, same recovery expectations, same timelines. That's starting to change, but not fast enough. Here's what happens inside an older body when it goes under general anesthesia. The heart has to work harder. The lungs take longer to clear the anesthetic. The kidneys slow down processing medications. And the brain, this is the one that surprises people. The brain becomes temporarily disoriented in ways that can last weeks or even months. Doctors have a name for it: post-operative cognitive dysfunction. And in patients over 70, it happens far more often than anyone admits. Now, I want to be absolutely clear about something. Age alone is not a reason to avoid surgery. I have operated on 80-year-olds who bounced back faster than some 50-year-olds. Age is just a number, but frailty is not. Frailty is a medical term. It means the body's reserve has dropped below a critical threshold. Roughly 40% of people over 75 show signs of frailty. That number jumps to nearly 60% over 85. So here's the real question. It's not whether someone can survive the operation. It's whether they can survive the recovery. Those are 2 very different things, and that distinction is going to matter a great deal as we move through each of these 5 surgeries right now. Surgery number 1, open heart surgery in frail patients' coronary artery bypass grafting, CABG as we call it, is one of the most common major surgeries performed on older adults. The concept is straightforward. Your arteries are blocked. We reroute the blood flow, and for the right patient, it works beautifully. But here's what the brochure doesn't show you. Open heart surgery requires stopping your heart completely. We place you on a bypass machine, a device that takes over the work of your heart and lungs while we operate. For a 60-year-old in good shape, that's manageable. For a 78-year-old with kidney disease, mild diabetes, and early cognitive decline, that bypass machine is a serious assault on every organ in the body simultaneously. Studies show that in frail elderly patients, open heart surgery carries a 30 to 40% risk of major complications: stroke, kidney failure, prolonged confusion, extended time on a ventilator. And here's a number that stops people cold. Up to 15% of high-risk elderly patients do not survive the first 30 days after this surgery. So what's the alternative? In many cases today, there is one. It's called TAVIE, transcatheter aortic valve implantation. A catheter-based procedure that never requires stopping the heart or opening the chest. Less dramatic than open surgery, but far kinder to a body that needs precision and care. Not a war fought on 6 fronts at once. Does this mean you should refuse heart surgery? Absolutely not. It means you should ask your surgeon one direct question. Am I a candidate for a less invasive approach? That question alone could change everything. Surgery number 2. Aggressive spinal surgery. Back pain in your 60s and 70s is nearly universal. I don't know a single patient over 70 who hasn't brought it up. And the solution that gets offered more and more often is spinal surgery, fusions, multi-level decompressions, hardware inserted up and down the spine. Now, I need you to hear this clearly. Some spinal surgeries are absolutely necessary, No debate. A spinal cord being actively compressed, causing loss of bladder control or progressing paralysis. That requires surgical intervention, promptly and decisively. But elective spinal fusion for chronic back pain in an elderly patient. The evidence is genuinely troubling. A major study published in the journal Spine found that in patients over 65, complex spinal fusion had a complication rate exceeding 40%. 40%. And the most common complications weren't minor: blood clots, infections, hardware failure, and something called adjacent segment disease, where the vertebrae above and below the fusion begin breaking down because the mechanics of the spine have been permanently altered. The hardware locks one section rigid, and the rest of the spine absorbs the consequences. Here's what frustrates me most: the pain relief itself. Studies show that for many elderly patients with degenerative spine disease, aggressive surgery provides no better long-term pain relief than physical therapy and targeted injections. No better outcome, but with dramatically higher risk. I had a colleague, a brilliant spine surgeon, who once said to me, "Adewale, sometimes the best operation is the one you don't do." I've carried that with me ever since. It's one of the most honest things I've heard in 20 years of surgery. Have you ever been told surgery was your only option for back pain? Drop that in the comments. I want to know how many of you have heard those exact words, because I suspect it's more than anyone realizes. Surgery number 3, major cancer resections. This one is the hardest to discuss, and I say that as a man who does not shy away from hard conversations, because when someone hears the word cancer, the instinct is immediate and powerful. Cut it out. Remove it. Eliminate it. I understand that completely. I would feel the same way. But here is what 2 decades in the operating room has taught me. The goal of treatment is not simply to remove the tumor. The goal is to give the patient more good years of life. And sometimes, not always, but sometimes, major surgery in a frail elderly patient does the exact opposite. Let me give you a concrete example. Pancreatic cancer surgery, the Whipple procedure, is one of the most complex operations in all of medicine. We remove the head of the pancreas, part of the small intestine, the gallbladder, part of the bile duct. The surgery itself runs 6 to 10 hours. In younger, healthy patients, it can be genuinely life-saving. But in an 80-year-old with heart disease and reduced kidney function, the surgery may technically succeed. The tumor is gone, and the patient still passes away within weeks. Not from cancer, from the operation. This is called futile surgery, and it is more common than anyone in this profession wants to admit out loud. A landmark study from the American College of Surgeons found that nearly 1 in 5 elderly cancer patients who underwent major resection experienced what they call failure to rescue, meaning a complication occurred that the weakened body simply could not overcome. So what's the conversation worth having? Ask your oncologist this directly. If we don't operate, what does watchful waiting, radiation, or targeted therapy look like for someone my age and health status? That question opens a door many patients never even knew existed. And sometimes what lies behind that door is genuinely the better path. Surgery number 4, elective joint replacement in severely ill patients. Hip and knee replacements are among the most successful surgeries ever developed. I say that without reservation. For the right patient, a new hip genuinely transforms quality of life. People go from barely walking to hiking trails, playing with grandchildren, living fully again. The results can be remarkable. But here is where it becomes complicated for older adults. The word elective means the surgery is planned, not an emergency. You have time to think. You have time to prepare. And crucially, time to ask whether this is the right moment for your specific body. Because here's what the statistics show. In patients over 75 with 3 or more serious health conditions, heart disease, diabetes, chronic kidney disease, obesity, elective joint replacement carries significantly elevated risk of perioperative complications. Blood clots are the most serious danger. Deep vein thrombosis, clots forming in the legs, can travel to the lungs and become life-threatening pulmonary embolisms. In elderly patients with reduced circulation, this risk is substantially higher than in younger patients. Add postoperative pneumonia from prolonged immobility. Add hospital-acquired infections. The picture becomes far more complex than the standard pre-surgery conversation typically covers. I want to be precise here, because I don't want to frighten anyone away from a surgery that might genuinely improve their life. The question is not, should I ever have a joint replacement? The question is my body in the best possible condition right now? Optimizing blood pressure, blood sugar, body weight, and cardiovascular health before elective surgery can reduce complication rates dramatically. Some hospitals now require a formal prehabilitation program before scheduling these operations for high-risk elderly patients. That is exactly the right approach, and frankly, every hospital should adopt it. Has your doctor ever discussed prehabilitation with you before a planned surgery? Most patients have never heard that word. They absolutely should. Surgery number 5. Emergency abdominal surgery. Now, I need to pause here for a moment, because this one is different from the others. You don't choose emergency surgery. It chooses you. A perforated bowel, a ruptured appendix, internal bleeding. These situations don't wait for a calm conversation in a clinic office. They arrive without warning and demand immediate decisions. But here's precisely why it belongs on this list. Knowing the risks in advance, before the emergency happens, changes how families make decisions in those terrifying, disorienting moments. Emergency abdominal surgery in patients over 75 carries some of the highest mortality rates in all of surgery. We're talking 30 to 50% in the most severe cases. Not because surgeons lack skill, but because an elderly body under sudden trauma is fighting on too many fronts simultaneously. The liver, kidneys, heart, and lungs are all compromised at once, and the inflammatory response that a younger body brings under control within days can spiral in an older body into systemic inflammatory response syndrome, a cascade of organ dysfunction that becomes extraordinarily difficult to reverse. So what can you actually do with this information? 2 things, and both of them are within your control right now. First, do not ignore abdominal symptoms. Persistent pain, unexplained bloating, significant changes in bowel habits in someone over 60 deserve prompt medical evaluation. Catching problems early means treating them before they become emergencies. That single habit can change everything. Second, have the conversation with your family now, not in a hospital corridor at midnight. Now, what are your wishes if emergency surgery becomes the only option? What quality of life matters most to you? These conversations are not morbid. They are not defeatist. They are one of the most responsible, loving things you can do for the people who will one day be standing in that corridor, terrified, trying to make the right call on your behalf. What you do with this knowledge. All right, we've covered 5 surgeries. Now let's talk about what you actually do with this information, because knowledge without action is just anxiety. And that is the last thing I want to leave you with today. Before any major surgery, planned or recommended, there are 4 questions every patient over 60 should ask. Write these down. Question 1. What happens if I don't have this surgery? A good surgeon will give you a straight answer. If the honest answer is that nothing urgent changes in the next 6 to 12 months, you have time. Time to think. Time to get a second opinion. Time to optimize your health before making any decision. Question 2. Is there a less invasive alternative? Medicine has changed enormously in the past 15 years. Robotic surgery, endoscopic procedures, catheter-based interventions. Options that didn't exist a decade ago are now available in most major hospitals. If your surgeon hasn't mentioned them, ask why. Question 3. What does recovery realistically look like for someone my age and my specific health profile? Not the average patient. You, your heart, your kidneys, your current medications, your living situation. The answer should be specific. If it sounds generic, push back and ask again. Question 4. And this is the one most people never ask. What is your personal complication rate for this procedure in patients over 70? Surgeons track this data. They know their numbers. A confident, honest surgeon will tell you without hesitation. If they seem uncomfortable with the question, That discomfort is itself valuable information. Reason for hope. Before I bring this home, I want to give you something genuinely hopeful, because this is not a video about fear. It is a video about options, and those options have never been more powerful than they are right now. Minimally invasive surgery has transformed what's possible for elderly patients. Laparoscopic procedures with small incisions and camera guidance dramatically reduce recovery time. Robotic-assisted surgery allows a level of precision that human hands alone cannot consistently achieve. Catheter-based cardiac interventions have opened doors for patients who would never have survived traditional open surgery a generation ago. And beyond surgery itself, and this is something I wish far more patients were told, optimized medical management is genuinely powerful. The right combination of medications, supervised physical therapy, targeted injections, and nutritional support can manage many conditions that previously seemed to require a surgical solution. The body wants to heal. Sometimes our job as surgeons is to step back, remove the obstacles, and give it the tools it needs to do exactly that. Gerald's story. I want to tell you about a patient. I'll call him Gerald, 71 years old, retired engineer, sharp, analytical, and not easily impressed. He came to me after 3 different surgeons had recommended open-heart surgery for a blocked coronary artery. 3 surgeons, 3 separate consultations. The same recommendation every time. Gerald wasn't afraid of surgery. He was afraid of losing himself. He'd watched his wife go through a major operation 2 years earlier and come out confused, exhausted, and never quite the person she had been before. He sat across from me and said, "Doctor, Morgan, she went in as my wife and came out as someone I had to take care of." That sentence has stayed with me ever since. When I reviewed Gerald's full profile, his kidney function, his frailty score, his cognitive baseline, I sat with him for 40 minutes, not 15, 40. And I told him the truth as I saw it. Surgery was an option, but so was an aggressive medication protocol combined with cardiac rehabilitation. The published data for his specific health profile showed comparable 5-year outcomes between the 2 approaches. He chose the non-surgical path. That was 4 years ago. Last month, he sent me a photograph. He's standing at the top of a hiking trail in Colorado with his 2 granddaughters, both taller than him now, and he's grinning like a man who knows exactly how lucky he is. The most important thing I will say today. Here is what I need you to understand. This is the single most important thing I will say in this entire video. A surgical recommendation is not a verdict. It is the beginning of a conversation. You are not a passive recipient of medical decisions. You are an active participant in your own care. The moment you walk into a surgeon's office, you carry with you the right to ask every hard question, to request every alternative, and to take every day you need before deciding. The surgeon holds the scalpel, but you hold the choice. And that choice, made with full information, clear eyes, and the courage to ask uncomfortable questions, is the most powerful tool in medicine, more powerful than any operation I have ever performed. Bringing it all together. 5 surgeries that carry serious hidden risks for people over 60. Open heart surgery in frail patients, where less invasive alternatives now exist and deserve to be part of every conversation. Aggressive spinal fusion, where the evidence for pain relief is far weaker than most patients are told and the risks are far higher. Major cancer resections, where the true goal must always be more good years of life, not just a technically successful procedure. Elective joint replacement in severely ill patients, where timing and preparation matter as much as the surgery itself. And emergency abdominal surgery, where the best protection is catching problems early and having honest, direct conversations with your family before the crisis arrives. None of this means avoid surgery. Surgery saves lives every single day. I have seen it. I have been part of it. I am proud to have given decades to this work. The message is this: be an informed patient. Ask the hard questions. Request the alternatives. Get a second opinion, and if necessary, a third. Your age is not a liability. Your experience, your self-knowledge, your willingness to advocate for yourself, those are genuine assets in any medical setting. What is the one question you would most want to ask your surgeon before a major operation? Tell me in the comments. I read every single one. And if this gave you or someone you care about a clearer way to think about a surgical decision, share it. That one share might matter more than you know. Take care of yourselves. Stay informed. Keep advocating. You deserve a surgeon who explains everything, and a medical team that treats you as a full partner in every decision. One final note. Everything I've shared today is general medical information based on published research and over 2 decades of clinical experience. Every person's situation is unique. Before making any decision about surgery or treatment, please have a full, honest, unhurried conversation with your own doctor or specialist. They know your history, they know your body, and that conversation, informed, direct, and respected, is exactly where good medicine begins.